Hello out there. I'm Abdurrahman Muhyiddin Adam, a medical student in Mogadishu, Somalia, University of Somalia, College of Earth Science and Technology. And here we go. I want to talk about something that every medical student should need to know. And this is a pulmonary embolism. Pulmonary embolism, as we know, is a disease which causes clots in the blood vessels, clot in the blood vessels, mostly in the deep venous thrombosis of the legs, and arises there and occluded into the lungs of the heart or something else. And these usually 79% arise from the deep venous thrombosis, which has a normal significance. DVTs arise 79%, and there is other embolisms like septic emboli from infective endocarditis. You have genuine lesions, new murmur, new fever, and streptococcus against your sore throat and something some sort of like that, and you get a septic emboli. Other things, air emboli. The most common cause of air emboli is needle. The needle with air, you insert it into the blood vessel and tributaries, and then here it goes, the emboli into the log, into your blood vessels, and occluded it. Other things, fat, blah 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 blah. This is not important. The other thing I want to talk about to you is mostly pulmonary embolism arises from the DVT. There is a something called virchostriad, elevated hypercoagulation, and some sort like that. You need to know about that. There's virchostriad, and the most sign that the patients of pulmonary embolism has most clinical presentations, they will become dyspneic, acute dyspnea and acute chest pain. Acute dyspnea and acute chest pain. What's the most common cause of acute chest pain? Stop it. But what is the most common cause of acute chest pain is like a C. It's more and more and more and more diseases that cause acute chest pain. But this chest pain, this pattern of chest pain, which pulmonary embolism have, is a acute pleuritic chest pain with positional and tender. Pleuritic, positional, and tender. Pleuritic, positional, and tender. And this is caused by 4 P's, called pulmonary embolism, pleural effusion, pulmonary edema, and pneumothorax. These 4 pattern of diseases that causes acute chest pain with pleuritic, positional, and tender. Sometimes the patients of pulmonary embolism had a stroke. How they caused the stroke? Because there is a venous embolism arises from the vein and comes to the lodge into the lungs. Why? Because arterial venous arterial occlusion. Why? As we know, the venous thromboembolism. Why do they call the venous? Because it arises from vein. Rare types comes from arteries. This is called paradoxical thromboembolism, and there is a okay, I know that, nothing more. And the patient has paradoxical thromboembolism. Paradoxical means there is a previous clot logged into the pulmonary veins, and this will increase the pulmonary venous pressure and will cause pulmonary hypertension. Other clot arises from the DVT and aneurysm in subclavians or arise from there, and when it comes into the pulmonary vein, there is high pressure and they not enter the pulmonary veins. What we make is to retrograde and penetrate the foramina valley, left ventricle, and to the systemic arterial embolism, which causes stroke. The other thing I want to talk about the stroke is a pulmonary, not stroke, pulmonary embolism. Clinical features are dyspneic, blah 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 blah. While you want to run some tests like X-ray, you need an X-ray to exclude the other diseases as pneumothorax and that have acute chest pain with pleuritic, positional, and tender. Pleuritic, positional, and tender. You will see nothing Nothing at all. Normal X-ray. You will need to ECG to test ECG. ECG will reveal sinus tachycardia. Why? Because there is a low perfusion to the peripheral tissues, and heart tries to compensate this and will increase the heart rate. This causes sinus tachycardia. The other thing I want to talk about is there is T-wave inversion, and T-wave inversion we know that there is a loss of ventricular repolarization. The other thing that may feel an ECG is sometimes right bundle branch block. What is the appearance of right bundle branch block on the ECG? That is a right axis deviation. Right axis deviation. Okay, okay. We will need to arterial blood gas in the first condition, for the acute condition. This is also normal BO and normal BCO2. The other thing you will need to know that ABGs you will see respiratory acidosis because of air trapping, and you will need to test the D dimer. What's D dimer? Who will tell me what's D dimer? D dimer is an product of fibrin. What's fibrin? And the product of fibrinogen. What's fibrinogen? Plasma protein in the liver. Who stimulated it? Factor no, thrombin. Who stimulates thrombin? Prothrombin. Who stimulates prothrombin? Factor 10. Who stimulates factor 10? Factor 8, 9, 12. That's how we made the clot. Okay, all clotting factors are forming in the liver except one. What is that factor that's not made in the liver and started it? Is factor 8, valve membranous factor, which started into the endothelial cells. Endothelial cells. That's right. The other thing that you will need about D dimer is elevated D dimer is a sign of pulmonary embolism. What did you say D dimer? How do you measure D dimer? By ELISA test. ELISA test. Okay, you will need some CT angiography, CTPA. Sometimes you do it on embolectomy, cutting off. Okay, pulmonary embolism is so deep, and we're gonna discuss it again later. I am late into my lecture. I have a lecture today about intestinal obstruction with Dr. Amin, and I have a discussion on clinical rotation on Uniso Hospital. So good luck to you, and we will meet other times. As I said, okay.